Alaikum. Good day, everybody. So today I will talk about the role of risk factor modification in managing atrial fibrillation. I will talk basically about AFib prevalence and impact on the healthcare system. And also I will talk about the modifiable risk factors and the development of atrial fibrillation. In addition, how modifying risk factor can manage and prevent atrial fibrillation. I will highlight some point on the gaps in the current healthcare system for AFib management. Also, we need a structure and focus approach through atrial fibrillation clinic when we manage these things. In addition, what is the evidence of improved outpatient through the specialized care? This is the first published ECG with atrial fibrillation with Enthoven ECG machine. Thomas Lewis wrote his first article about the auricular fibrillation is a common clinical condition, and till now it is a very common clinical condition with a bad threat. More than 33 million number of people affected worldwide, and almost 5 million new cases per year, and almost 40% of lifetime risk of atrial fibrillation in population more than 55 years of age. The problem of atrial fibrillation, you will get the combined, or the DAL is the combined impact of premature death and the years lived with disability due to atrial fibrillation is increasing over time. From 1990 till 2019, it is very high and getting worse. The reason for this may be stroke, heart failure, dementia, and increased mortality. More things worse, the atrial fibrillation is expected to increase more than 60% by the year of 2050. And if you look to here to the countries, it will be doubled or even more than double. The problem of rising prevalence in this case, in this country, will increase the burden in the health resources. The progressive innovation, as you can see here in the slide, in the field of AFib management failed to, that have been introduced over time, which include drugs, cetalol, digoxin, quinidine, and even catheter ablation did not impact much on the prevalence, outcome, and the health cost of this healthcare system. So the main issue here, if you cannot treat the disease, you have to prevent it. And unsurprisingly, many modifiable risk factors associated with the atherosclerotic cardiovascular disease associated with atrial fibrillation. And these risk factors basically result in severe mechanistic changes, atrial remodeling in the atrium by all these factors, the obesity, hypertension, diabetes, smoking, etc., all lead to a formation of the atrial substrate and atrial fibrillation. So if you find a way to prevent atrial fibrillation by modifying these risk factors, you will prevent atrial remodeling and prevent atrial fibrillation, and you prevent the atrial outcome, recurrence, stroke, the healthcare morbidity and mortality, and the impact on the care system. There is a stepwise increase in atrial fib risk with increasing number of risk components. If you have diabetes, hypertension, you will be likely to get it more than if you have just only smoking alone. So the more risk of atrial fibrillation. Knowing this, the prevalence of these risk factors in Saudi Arabia is really very high, diabetes and obesity. The question is, does atrial fibrillation substrate improve after successful ablation? If you look to this paper, long-term effect of catheter ablation for lone AFib, show there is a progressive atrial substrate despite successful ablation. They took 11 patients and they ablated them, compared them to control, looking for criteria for atrial fibrillation or finding in the atrium, like bipolar voltage, conduction, refractory period of the atrium, and single complicity. As you can see here, this is a control. This is the 3D mapping of the atrial fibrillation patient showing low voltage with red color here and shows slow conduction, more prevalent complex signals. And if you follow them up later on after successful ablation, you get things worse, lower voltage, no improvement in the conduction, and maybe prolongation of the refractory period. And also the phase signal and the conduction time is more worse with follow-up. This will raise the question why the substrate in some patients may continue to progress even after the AFib is resolved. And we see this commonly. Sometimes we ablate the patient, he has multiple recurrence. One of these reasons, or two reasons, main reason, is the timing of intervention. If you do your ablation very years late after the AFib, you may not get it. And also, if you have a risk factor that give you the atrial fibrillation, you might not improve the patient. We learn from the East AFib Net 4 trial that early intervention within a year, with whatever strategy you have, catheter or drugs, reduce the risk of cardiovascular complication. So early rhythm control versus the usual control. If you intervene early, you will have the better outcome. The reason, as I said before, if the atrial fibrillation is still longer, the atria will be damaged, and which makes it difficult to return to the sinus rhythm. The second point is maybe persistent of risk factor, and these are the risk factor, namely the obesity, hypertension, diabetes, and extra. Remember that there is my atrial fibrillation or other patient atrial fibrillation different from patient to another. Basically, the substrate modification or substrate formation is different from patient to patient. Obese patient, they may have more fatty infiltration in adipose tissue. Hypertensive patient, they may have a large atrial muscle. One of the important risk factors is obesity, and up to 30% if you have increase 5 points in the BMI, you're likely to get atrial fibrillation. And so on, significant weight loss is associated with reduction of the risk of atrial fibrillation. This obesity was tried in an animal model, and they look for the atrial substrate due to the progression of weight gain. They brought sheep and they feed them and they get the weight gain, and they look to their anatomy and pathology. Atrial fibrosis is noted in the atrial changes, fat infiltration, and increase in the atrial fibrillation. In the same reverse talking, if you in the animal model, if you get a patient with obesity and then reverse it back to lose weight, you will lose this remodeling and you reduce this infiltration with fat. For example, here, if you reduce your weight by 15% of the animal models or 30% compared to the lean control and obese, you will go back to normal atria. So this modifier risk factor is really underutilized in our current practice and could play a significant role in atrial fibrillation management. And also it can reduce the impact on the healthcare system. And also it will give the patient a lot of atrial fibrillation free time. Is there an evidence to, if you're targeting all these risks combined or isolated, the AFib recurrence will improve? The answer is yes. Before I showing the evidence, what do you mean by targeting or optimizing these risk factors? Glycemic control, more than 10% reduction or below 6.5, weight loss more than 10% or BMI less than 27, exercise 220 minutes per week or 30 minutes a day. Blood pressure below 130, you treat the obstructive sleep apnea. The trials involved in these, when we're treating all the combined, targeting all risk factors, the main trials are Legacy, arrest atrial fibrillation, and cardio-fit trials. If you look, all of them, they are improving the atrial fibrillation burden and symptoms and freedom from atrial fibrillation for a long period of time. And the benefit most, if you lose your weight more than 10%, is better than losing less than 10%, better than losing than 3% in all these trials. If you combine of loss of weight with exercise activity more than 2 minutes, you get a free time of survival or freedom from atrial fibrillation. If you look, for example, here in Legacy trial, the recurrence, if you have more than 10% weight loss, you're likely to get atrial fibrillation, freedom from atrial fibrillation, 86%, better than our result or literature result for atrial fibrillation. And if you look to the cardio-fit, if you combine weight loss more than 10%, exercise more than 2 minutes, it will be 94%. In addition to that, what would make your procedure successful if you have control these risk factors as it's shown in arrest AFib trial. Also, the type of atrial fibrillation, paroxysmal and persistent. If you have you are not losing weight, your atrial fibrillation type, paroxysmal, will progress to persistent. The paroxysmal progress to persistent. And if you lose a lot of weight, more than 10%, the persistent will progress to paroxysmal, to the improvement side. The isolated risk factor, targeting one by one, just only one of them, leaving the other. Many trials involved, but remember that you are dealing with multiple risk factors. If you treat one, not necessary that you will improve the whole condition. I will start with diabetes, and if you control your diabetes, hypoglycemic control, the glycated control, the blood sugar control for a year before the ablation, more than 10% reduction, your patient will get free from atrial fibrillation recurrence. If it's less than 10% control before the ablation, the recurrence is significant. If you have increase in the atrial fibrillation, you will have bad outcome in terms of the recurrence. In the same token, hypertension as isolated factor, in this case is severe hypertension and eradicate AFib with renal denervation, post-BVI isolation, better outcome because managing the severe hypertension. The same things, exercise also improve the outcome with the patient if you exercise half an hour a day. The other risk factor, obstructive sleep apnea, linked to the development of atrial fibrillation, but there is some result is contradicted in certain cases. As I said before, if you have more than one risk involved and you treat one factor, you may not change the whole picture. For example, here, you are treating hypertension alone, not severe, just only mild. The result, there is no change in the outcome of atrial fibrillation recurrence. So these factors has to be tackled, all of them, if possible. So what is the challenge we do have? What is the solution to manage these modifiable risk or atrial fibrillation? The best approach for this is to use the integrated care model, which is targeting the modifiable risk factor as an essential fourth pillar. Instead of we just concentrating on anticoagulation, rate control, rhythm control, you have to concentrate significantly about lifestyle and risk factor modification. And this is really a process of working with atrial fibrillation patient to achieve the risk factor management and maintain the sinus control according to the guideline controlling the risk factor. So how can we do it? Basically, we do it through atrial fibrillation clinic. We do have atrial fibrillation managing team, which is the usual team, cardiologist or electrophysiologist. He focuses on rate, rhythm, or oral anticoagulation, initiate the motivation, emphasize it is possible. And the other team is the risk factor team management, focus on risk factor solely, provide action and plan for the patient, maintain the motivation, and if there is any barrier to determine it. Atrial fibrillation clinic, with the risk factor management team can be a physician, can be a nurse or a pharmacist, and they should have an access to the other support care, like sleep physician or endocrinologist. And all of this need really an administration support. It's usually 30 to 6 minute consultation, 3-month appointment, and weekly contacting the patient through messages or email or WhatsApp or phone. So basically the 4 key elements of integrated care is patient involvement in patient education. You educate the patient, lifestyle modification, share the decision plan, multidisciplinary team, endocrinologist, pulmonologist for sleep apnea, technology you may use for checklist communication, monitoring the patient, clinical decision support as a protocol. And you have to have all access for the therapy from drugs to ablation. The main focus is the patient, with the primary team is cardiologist or electrophysiologist, nurse and pharmacist, with all multidisciplinary referral site if possible. So basically the atrial fibrillation clinic, the integrated care model, is a structured healthcare delivery, patient-centered, focus on the patient, and tailored to the individual. Is there an evidence for this atrial fibrillation clinic would work? Yes. As you see here, the nurse-led care of patient of AFib is superior to the usual care provided by the cardiologist in terms of cardiovascular hospitalization and cardiovascular mortality.
We have 1 minute, Dr. Abdulmohsen.
Yeah, 2 minutes. Huh? The other form of atrial fibrillation clinic in UK is called the ABC pathway, and it is a holistic approach to atrial fibrillation care, focusing on the main pillar of atrial fibrillation. Basically, you avoid stroke, better symptoms, and to manage the cardiovascular risk. Avoid stroke, knowing which is a lower risk, high risk, and treat the symptoms and modify the risk factor. And this kind of system, or the atrial fibrillation clinic, or the integrated model, AFib care model, it will tell you the gaps in the healthcare system outcome. For example, anticoagulation. There is a suboptimal rate of anticoagulation, prescription, and adherence. The symptoms, there is a deficient in symptom identification between control and the management, and also regarding the comorbidity, insufficient comorbid cardiovascular risk factor investigation and modification. So basically, atrial fibrillation clinic, or this model, serves as a roadmap for the clinical practice. This AB system pathway, if you adhere 20% or 80% or 50%, can tell you how much it will save from stroke prevention with this AB system, or the bleeding prevented with this system, the whole death from any cause of death, or the cardiovascular death. So basically 60% reduction in death, and 60% also cardiovascular death, 45% ischemic stroke, and 30% main bleeding. More important, the impact on care health system will be reduced. The cost will be reduced if you are using the usual way compared to the ABC pathway. So what are the barriers for this AFib integrated care model? Usually, the main ruler is healthcare system, physician issue, and patient issue. Usually support from the healthcare system, the physician. Can I have just the last slide? He cut it off.
The last slide, please.
So we as a physician, we don't have time to discuss with the patient all factors. Patient may have lifetime behavior, too hard to commit. For sure, the integrated care of atrial fibrillation management improve the outcome, reduce the healthcare system, and enhance patient satisfaction. So I would like to conclude, atrial fibrillation is a manifestation of systemic illness associated with unhealthy lifestyle and poorly controlled risk factor. The usual management or the traditional management of atrial fibrillation has focused on the sequelae of the systemic disease rather than the underlying cause. There is several recent published studies support that, and also we should targeting the modifier risk factor as a fourth pillar. Unfortunately, there is no data from Saudi Arabia discussing this issue and the impact on the clinical side. Thank you very much.